Thank you, Mr. Chairman, and I want to thank all of you and Congressman Kennedy. It's good to see you again. Yes, I want to start with, it's no accident that New Hampshire, West Virginia, we're here as a smaller states really keyed in on what these issues are. The senator from New Hampshire mentioned they were the second highest state for opioid overdose deaths. Unfortunately, Senator Manchin, our state's number one in West Virginia. In the year 2015, we had 638 deaths, and we expect that to rise over the next several years. So, Dr. McCants-Katz, a few weeks ago, we introduced a bipartisan piece of legislation with Senator Shaheen, Senator Manchin, and Senator Hassan from the smaller states when we're talking about targeting resources. The state of West Virginia, under 21st Century Cures, the first $485 million that went out. The state of West Virginia, $6 million. And what did you tell me, state of? Six. Over 2 years for New Hampshire. So we have decided that this is not going to help us solve this problem. And what we're trying to look at is encouraging SAMHSA to look at mortality rates, lack of access to treatment and services when doing the state-targeted response to opioid crisis grants. In other words, let's weight these grants to where the greatest needs are. Everybody, yes, can get something, but not population size. I was actually looking at the top 6 states, West Virginia, New Hampshire, Ohio, Rhode Island, Massachusetts, Kentucky, Maine, Connecticut. These are smaller populations, relatively smaller population states, and that have the deepest problems at this moment. So, do you understand what we're trying to get here, and what would your reaction be to? And we've talked to Secretary or to Seema Verma about this, and seems to be an understanding concept. Do you have a reaction to that?
Well, what I would say, Senator, is that when we were considering the funding formula for the second year of the STR money, in order to make any change at all, federal regulations would require that every state submit a new application. That we thought would be possibly very disruptive. We were getting a lot of feedback from the states that there was reluctance to move forward with the plans that they had formulated because they weren't sure of what the funding would be. And so the decision was made to stick with the funding formula that was decided that had been decided on for the first year, and to look for additional resources for those states hardest hit. Of course, West Virginia and New Hampshire being two of those states. What we have done at SAMHSA has been to review whether we could find some additional resources to bring to bear on the problem, particularly for the hardest hit states. And you may know that we released a funding announcement a few weeks ago that is targeted to the 10 states that have the highest rates of opioid overdose death and the highest change rate of opioid overdose deaths. So we found resources to do that. We also have been able to put together a new funding announcement for a new way of providing technical assistance to states. We were able to put $12 million into that. That will be technical assistance and training that is going to be individualized to states and their communities that need to provide resources to treat opioid use disorder in terms of prevention, treatment, and recovery. So we are trying as best we can to bring more resources to those states hardest hit.
Well, I think you can look for us to be very aggressive on working to be more encouraging to you, either regulatorily or through the legislation, to make sure that because if we don't stop this epidemic in West Virginia and New Hampshire, then the numbers are going to go up proportionally in all of these states. This is so we have an opportunity here. $6 million sounds like a lot in some circles, but when you try to do treatment and recovery and prevention and NAS babies and everything else, that's the comprehensive solution, it's just not even. It's barely hitting the bucket. Last question. I'm sorry to go a little bit further here. In the little town of West Virginia, Kermit, 9 million prescriptions were sent in 2 years in a town of 392 people. Overall, in the state of West Virginia, between 2007 and 2012, 423 million opioid painkillers in the state of West Virginia. We have 1.8 million people. Dr. Howard, you talked a lot about tracking prescription drugs. How did this happen? Did you all of a sudden wake up to this and decide that this was something you need to track and improve? Well, where were these numbers 5, 10 years ago that we weren't recognizing this problem?
So for prescriptions, we've actually been able to get this through an IMS database, so it's not a CDC database. So we've been tracking this for the past few years, and we reported on this summer in one of our vital signs showing that there's a difference in counties by 6-fold sometimes. And so one of the things we're doing, including in states like West Virginia, is we're looking for where there's high prescribing rates and making sure that local health departments go out to those communities to be able to provide education to providers who might be overprescribing. Another thing we're doing is with states like in Tennessee, now providers are learning what is their prescribing rate in relation to others within their own specialty to see if they are overprescribing, to really help educate and bring the prescribers into this.
I mean, I think, these stats have gotten better, but the fact that they were where they are is just astounding, I think, to all of us. Thank you.
Thank you, Senator.